Hello, everyone, and welcome to today's special webinar to mark World Evidence-Based Healthcare Day. Bonjour à tous et bienvenue à ce webinaire spécial. Je suis Suzanne McGurn, la PDG de la CADTH. I'm Suzanne McGurn, President and CEO of CADTH. I'd like to begin today by acknowledging that I'm speaking to you from Ottawa, Canada, located on the traditional unceded territory of the Algonquin and Anishinaabe people. Thank you to the Algonquin and Anishinaabe people who have been the keepers and stewards of this land since time immemorial. I recognize that people are joining us today from various locations across the country and internationally. And I'd like to encourage you all to think about where you live, work, and play. And to take a moment to acknowledge and think about the people who have lived there before you, who have cared for and sustained the land you call home, and continue to live in your community, advancing the care for the environment that you spend so much time in. I think it is particularly important today on the topic that we're talking about to acknowledge that there is a critical need for Indigenous perspectives in our healthcare systems. First Nations, Inuit and Métis people have and continue to face systemic racism and prejudice in accessing healthcare across Canada. I'm pleased to be with you today to recognize on October 20th, World Evidence-Based Healthcare Day. So over the course of the next couple of days, you're going to see more and more about the topic of evidence and equity. This year's theme is evidence and global health equity. There are events all over the world like this one today to raise awareness and encourage concrete steps towards equity-centered, evidence-informed decision-making. Evidence is a prerequisite for achieving global health equity. And equitable health policies, systems, and services depend on a high-functioning evidence ecosystem with the generation and application of evidence. Equity is important here at CADTH. At CADTH, we examine evidence. Health administrators and policy experts rely on CADTH to help inform their decisions about the life cycle management and appropriate use of drugs, devices, and services used to prevent, diagnose, and treat health conditions. Last year, we launched a new strategic plan that includes equity as one of its guiding principles. We actually added accessibility at the end of our first year after hearing feedback from others and thinking about what really was inclusive. We now refer to IDEA, inclusion, diversity, equity, and accessibility. With the strategic plan as our guide, we are taking an integrated approach to equity and applying an equity lens to the work we do here. Our colleagues that you will hear from later will share a bit more about what that looks like on the ground. Before I go on to introduce our esteemed panel today, I'd like to remind you, you will see on the screen an opportunity for how you can submit questions. Please feel free as the speakers are talking to include questions. I will be continuing to monitor it, and we will be circling back for a question and answer at the end of the session. I'm now very pleased to introduce our speakers for today. Dr. Avram Denburg is a staff oncologist and clinician scientist in the Division of Haematology Oncology at SickKids, the Hospital for Sick Children in Toronto. Avi's research is centered on childhood cancer care systems with a focus on pharmaceutical policy and drugs. His lab at SickKids Research Institute works on projects of health technology assessment and cancer drug access in various health systems and contexts globally. Avi has served as an expert member of CADTH's Pan-Canadian Oncology Drug Review and on the Ontario Steering Committee for Cancer Drugs. He also chairs the Drugs and Therapeutic Committee at SickKids. I'm also pleased to say that Avi is a member of the CADTH Board of Directors. Emil Reddy is the strategic lead for inclusion, diversity, equity, and accessibility at CADTH. Although joining us relatively recently, Emil has been working alongside community, government, health, academic institutions across Turtle Island to advance inclusion, diversity, equity, and accessibility through strategic leadership and cultural guidance since 2008. They bring a breadth of experience working alongside new immigrants, Indigenous youth, queer and trans communities, among many others. All the work that Emil does is rooted in his intersectional experience as a trans Asian and Native Pacific Islander. And Renata Axler is the ethics lead at CADTH, where she works to advance methods and practices related to ethics and health technology assessment. In all of the work across CADTH, Renata is also an adjunct lecturer at the Institute for Health Policy, Management and Evaluation at the University of Toronto, where she completed her PhD in health policy and bioethics prior to joining CADTH. Renata has been involved in several multidisciplinary research and policy initiatives examining the interface of ethics, health policy, and innovation. And with that, I'd like to turn it over to our first speaker, Avi.
Thanks so much, Suzanne. It's an absolute pleasure and privilege to be here and part of this esteemed panel. I have the unenviable task of speaking to you in 10 minutes or less about how we think about and capture evidence of equity in health research and in healthcare practice. So I'm going to try to do that through offering a little bit of a kaleidoscopic perspective on this and a metaphor, and hope that it helps spark some discussion. Next slide, please, Tristan. So first, a brief acknowledgement that really I'm coming to you with a particular perspective. I'm a white male settler physician and researcher at an academic institution in a rich country, which puts some blinders on. My perspective is really, it's a Western worldview steeped in philosophy and metaphysics and epistemology from the institutions I've been trained in, and the attendant social and political values inherent in those institutions. And by allopathic medicine and Western science. So my pursuit in that regard is to try to maintain some humility about the limitations in my perspective, have gratitude about the diversity of perspectives of those around me, and remain in solidarity with those whose perspectives might have been silenced or sidelined. Next slide, please. So some motivating questions for this segment of the talk, which I know will be expanded upon by Emil and Renata, and I hope we'll have some time to discuss. First one is the big one. What is equity? Who defines it, and how do we measure it? I also would like us to think a little bit about how we might incorporate equity considerations in clinical practice, in health research, and in policymaking. I think it's important to consider how we draw the boundaries of moral communities, and how should we. And also want us to think about how Canada can lead in equity incorporation in health policy and in HTA. We won't cover all of these things, but I hope that we'll at least begin to scratch the surface and generate interest. Next slide, please. So first, an attempt to situate equity. I think the first thing I wanted to say is that equity isn't all of what we think about or should think about when we think about ethics of healthcare and policy. It's one value amidst a broader set of values that are important to informing healthcare decision-making in a fair and just way. And albeit a really central, important one, it's one we should consider in the context of other values and perspectives. The next thing I think I want to do over the couple intervening slides that follow is really try to situate equity within theories of justice. So we understand where we're coming from when we talk about equity, and what perspectives might be missing. And hopefully provide us with a bit of a compelling visual metaphor that some of you may have seen before to understand really where equity is situated. Next slide, please. So this is a little bit of a busy slide, but I wanted to help us take a step back and at least walk you through how I think about equity. So whenever I'm thinking about the concept of equity, I like to go back to basics and think about what are we really talking about, and what is it grounded in. And at its root, when we're having discussions about equity, which is sometimes called fairness, we're really talking about justice. The major concerns of justice are what is owed to different people, and to whom those specific people are that it's owed, and on what basis. What are the conditions or criteria for which we should be seeking justice or granting justice? The formal principle of justice has been articulated, at least in Western philosophy, as equals being treated equally and unequals unequally. And that it really is at the root of some of the ways that we think about justice and therefore concepts of equity. And you can see in this table on the right of the screen when thinking about something like resource allocation in health systems, which is a core thing that CADTH does all of the time, and that we're really talking about a lot of the time when talking about equity and ethics in healthcare practice and research. Talking about equity as a solution is really only one perspective or one way of getting at the problem. That's really derived from philosophical strands of thought in Western canons, and thinks about distributive and procedural justice as the problem that is trying to be solved with equity. You could come at ethics of resource allocation in a variety of alternative complementary ways, including thinking about effectiveness, which we often do in the context of health sciences, thinking about scarcity in the context of economics and trying to be as efficient as possible to minimize the impacts of scarcity, and so on and so forth through political theory, social theory, and law. But we're going to spend today in the philosophical and justice arena thinking a little bit about equity. Next slide, please. So here's this equity metaphor, and there are different ways that this has been conceptualized and pictorialized. Many may have seen this. This is not mine. This is something that I've borrowed. But it really, for me, is a useful way of distinguishing between what we mean by equality, how that differs from equity, and how equity might actually be slightly different than broader conceptions of social justice. So when thinking about equality, next click, please, Jose. You can see in the picture on the right, we have really evenly distributed tools or assistance to both of these young people who are trying to pick apples from the tree. And this is really in philosophy circles, in egalitarian circles of philosophy, what's called formal equality of opportunity. So, they're given the same tools and resources, and on some level that's felt to be able to achieve equal outcomes, or at least give them the potential to do so. There's obviously lots of criticisms of that. You can see that they clearly don't have the same access to the apples on the tree by virtue of the nature of the tree. And so the notion of equity, next click please, is really the idea of fair equality of opportunity, or customizing tools and interventions to take account of different capabilities and different capacities for actually dealing with the system that's at play. And so it tries to level the playing field somewhat, in this case with a longer ladder, to get at a more fair equality of opportunity. And this is sometimes in philosophy circles called a capability approach. Next click. And one more click, please, Jose. So the last notion here is justice, or sometimes called social justice. And this really angles at equality of well-being or equality of outcomes of interest. And here the key differentiator is the understanding that there are systems that are structural and laced with power that might work to dominate or to oppress certain groups as compared to others, and that those systemic structures need to be attended to or fixed in order to really right the system and achieve equality of outcomes or well-being. So this is really, in Iris Marion Young's words, about the institutional systems that seek to enable people's self-determination. Next slide, please. So with that visual or metaphorical understanding of equity, I wanted to take a minute to talk a little bit about how we measure equity, because that's going to be a key concern for us as we work through this seminar. These are slides, pictures borrowed from a beautiful paper by Ross Upshur that was published over 20 years ago now. And what Ross and his colleagues were doing in this paper is thinking about evidence in healthcare broadly, not just equity, but how we come to know and understand things in healthcare research and practice, and the underlying epistemologies there, and different methods used to get at different ways of knowing in healthcare research. And this moves on the horizontal axis from the particularities of the context, be they very particular to, for instance, a given patient or circumstance, all the way to more generalized understandings of systems or processes. And then on the vertical axis, from different methods, from more qualitative methods that seek to understand the meaning of phenomena, to much more empirical measurement of phenomena through quantitative measures. I mean, I won't spend too much time delving into each of these quadrants, except to say that evidence in healthcare and in health policy making is never one or the other of these things, and that this the whole purpose of this quadrant is not to imply a hierarchy, but in fact to level the hierarchy and to suggest that we're going to need both meaning and measurement in terms of understanding evidence for healthcare policy and practice. And it's the exact same for our understandings of equity in health. Next slide, please. So then, how do we measure equity in healthcare policy and practice? And I want to suggest that we need to be thoughtful about perspectives. In other words, whose voices count when we're trying to make meaning of or measure equity. We want to think carefully about methods, and this alludes to this past slide. So what tools are we using, or what ways of knowing are we using to get at meaning and measurement? And then lastly, we want to think about boundaries. Who's in and who's out? Which people are we talking about when we're considering equity considerations or disparities in care, and how are we drawing those boundaries? Next slide, please. So what I want to do with the successive next few slides is really just give you a quick smattering of different ways of approaching thinking about and measuring equity in health, from the clinical arena to health research broadly, all the way from patient-facing stuff to population health. And then lastly, a little bit of a quick focus on HTA itself, given that we're going to spend the rest of the time in Emil and Renata's talks thinking a lot about instantiations of equity in HTA. Next slide, please. So here's a first example. I wanted to take something that was very familiar to me in the context of my own clinical practice and talk to you about it, because I think it'll hopefully help us raise some interesting issues. At SickKids, we work hard to make defensible, robust, and fair decisions about who can get access to really novel, expensive medicines. And this is with a view to promises to patients and systems around greater precision child health and to resource stewardship more broadly in the system. So when clinicians have a novel therapy that might not be that well understood from a traditional evidence perspective for potential use in a child, we have a process that's well fleshed out by which we make careful, deliberative decisions about which technologies, which drugs, which interventions the hospital should fund. And I wanted to give you that example without going into all the ethical principles that we invoke and work through, to suggest that there are real relevant clinical decision-making foci for thinking carefully about equity in health, and for juxtaposing equity with a range of other ethical principles to come up with fair and just decisions about access to healthcare resources. So that's my somewhat micro example from healthcare practice of equity at play and being measured or made meaning of in health. Next slide, please. So then to health research. And you'll all know, or many will be familiar with the fact that health research is a very broad concept that can range from doing work with individual or groups of patients, all the way to thinking about epidemiology at a population level. And I've just chosen two quick examples here to encompass that spectrum and think about different ways of thinking about or measuring equity in health research. The first on the left is an exercise that my lab undertook in the context of thinking about access to innovative therapies for children and youth in Canada. And we worked carefully with a range of citizens through successive citizen panels to elicit perspectives and preferences from those members of the public and patients and caregivers to try to understand the key values that should direct decision-making about access to new medicines and health technologies for children. And equity surfaced as one of the key values and was given some fleshing out by the patients we worked with. But as you can see in the somewhat busy Venn diagram, it was only one of a number of different values that were really emphasized, and it has some interactions with many of them. On the sort of middle part of the spectrum, there's health services research that really tries to look at the interaction between systems of care and health outcomes for different groups of patients. And I've selected what I think is a really nice study from some colleagues of mine at SickKids that looked at locus of care at end of life for adolescents and young adults with cancer to try to understand, are different children and youth and young adults getting differential access to high quality end of life care? And if so, how? And what do those disparities look like? So this is an exercise in measuring disparities, not necessarily in making specific meaning of them. But in this busy table, you can see that if you had a hematological cancer if you were treated at a pediatric center, or if you came from a rural home, you had a higher likelihood of dying in the ICU. Subsequent work in a similar vein have demonstrated that access to palliative care physicians actually diminishes the likelihood of high-intensity end-of-life care, including dying in the ICU. And so these are the ways that we can start to make sense of, what is equitable in terms of end-of-life care, and how do we level some disparities therein. Next slide, please. So another busy slide, but a couple of quick examples of what I think is really relevant work to be thinking about health equities in Canada. On the left is some beautiful work done by a colleague, Arjuman Siddiqui, and her colleagues on looking at health inequalities between unemployed and employed Canadians and decomposing those trends over time. What you can quickly see is that, first of all, there's a huge gap in poor self-reported health between employed and unemployed Canadians, and that gap is widening over time, with much poorer self-reported health amongst those who are unemployed. On the right, you can see what I think was a really beautiful study done on Toronto and on health outcomes amongst those with higher or lower incomes in Toronto across a range of different health indicators. And you can see that our city is unequal and getting more unequal. Most of the key indicators they measured demonstrated a stronger relationship between poor health and low income. Some of those got worse over time. And the only ones that became more equal favored less health inequality or less worse outcomes in high income Torontonians. So these are nice examples of studies that really are looking epidemiologically at the population level and social epidemiological terms at inequalities in health. Next slide, please. So one last example from the realm of HTA, and I should say, when thinking about health research in HTA around equity, we can think about everything all the way from priority setting around which technologies even come through the machine to get to an HTA body like CADTH, all the way to thinking about real-world reassessments of technologies. But this example is specific to how we make assessments of health technologies themselves. This is again work from my team looking at trying to create a framework to inform how we prioritize and value pediatric health technologies in the context of HTA, to inform rich deliberation by the bodies that CADTH so ably runs when making decisions about what to cover. So I won't go through all of the specifics here. I'm happy to talk about this in follow-up, but this is an example of how we're thinking about inequity in how we make assessments of health technologies in Canada and attempts to make that more equitable. Next slide, please. So getting towards the end, I promise, a last somewhat busy slide just to make the point that I think in terms of thinking about HTA specifically, we've made big leaps over time and are starting to think across the life cycle in terms of equity. So whereas in its initial incarnations, really HTA was premised on efficiency and economic paradigms of thinking about value, increasingly there has been careful thought given to and many publications on how to think about ethics broadly and how to think about equity specifically in the context of health technology assessments, both academically and in real world practice at various HTA bodies around the world. Next click, please, Jose. I think CADTH is leading in this. I think CADTH has an opportunity to continue to lead in this and amplify its leadership in thinking about equity in HTA. And really one of the key opportunities will be thinking about equity across the life cycle of technologies, all the way from priority setting through assessment and to reassessment. And I know that when we hear from Emil and we hear from Renata, we'll hear a lot about ways that CADTH is now carefully thinking about equity in its healthcare decision-making committees and more broadly. Next slide, please. So just to wrap up, I think I wanted to bring us back to the kaleidoscope made up by perspectives, methods, and boundaries. Really, we need to be thinking about whose voices we're including in the kaleidoscopic ways that might make different determinations about what is equity and its bearing on our decision-making. We want to think about incorporating manifold different kinds of methods to get at both meaning and measurement. And we want to think very carefully about how we're drawing the boundaries of moral communities so that we know who's in and we know who's out when we're talking about equity, and we can make conscious and careful decisions about how to continuously redraw those boundaries. So with that, I'm going to stop and humbly hand it over to Emil and subsequently Renata, who are going to talk to us about Indigenous knowledges and practices and equity in CADTH's work. Thank you.
Thanks, Avi. As already mentioned, my name is Emil Reddy. My pronouns are they, them, and I'm the strategic partner for IDEA, or Inclusion, Diversity, Equity, and Accessibility at CADTH. And today I have the honor to present the guidance that CADTH received by Indigenous health leaders on how best to review Indigenous knowledges and practices. So Suzanne had presented our guiding principles, and I think it's really important that we come back to this because our guiding principles really help guide the way that we do our work at CADTH. And it's through this principle that we apply a lens of equity and inclusiveness with the aim of fostering health systems that are representative of the diversity found all over Canada. Our guiding principles also impact our strategic pillars. And I really want to focus on the strategic pillar that is, thanks, Jose, that is anticipate, where we aim to enable a future-ready healthcare. Our work in the Indigenous communities falls under this pillar, and this is where we commit to continue to listen, learn, and engage with First Nations, Inuit, and Métis people, communities, organizations, and governments, with the goal of contributing to Indigenous health and wellness. Next slide, please. I think it's important to contextualize the challenges faced by Indigenous peoples in Canada's health systems. And this includes the historical inequities of Indigenous peoples and their experience of racism in healthcare. This has been well documented, and we need only to go back to the In Plain Sight report to see some of the evidence of this. Indigenous peoples also are impacted by a patchwork of coverage and often experience jurisdictional hoops when trying to access this coverage. We need to also recognize that there's barriers in recognizing Indigenous knowledges and medicines in data and research. And I believe that, or the Indigenous health leaders, as well as myself, believe that it is through all these barriers that have really created a need for Indigenous data sovereignty. And that is the First Nations principle of ownership, control, access, and possession, which is formally and commonly known as OCAP. So with this, CADTH engage Indigenous health leaders from across Canada to come together and provide us guidance on how best to prioritize Indigenous knowledges and practices. So on March 24th, we brought together a group of Indigenous health leaders from across Canada. And the objective of the meeting was to develop criteria, principles, and processes to help consider how we can support an Indigenous-led discussion to guide the prioritization of requests to CADTH with, for, and about Indigenous peoples. The meeting was successful in identifying several important recommendations that will serve to guide CADTH's initial work in this space, and all of which we did capture in an Indigenous health leaders summary report. So what did this report help us do as far as prioritization? Next slide, please. The first is I think that we need to be guided by a fundamental set of principles, and the Indigenous health leaders actually pointed us towards some current guiding principles, some which are found in UNRIP, as well as our Truth and Reconciliation call to actions. But we also need to acknowledge that CADTH, nor any other formal colonial institution, should engage in the assessment of any topics related to Indigenous traditional knowledge and medicines. I believe that is my belief, as well as the Indigenous health leaders' belief, is that is best kept in the Indigenous knowledge and cultural practices of Indigenous peoples themselves. We also need to prioritize partnership and relationship building with Indigenous peoples. And the Indigenous health leaders really wanted us to understand that if we look to emulate how Indigenous health communities prioritize their own health, we will likely be able to find some really great parallels to how we could do our work. And this would likely be led by an Indigenous advisory circle made up of Indigenous peoples from across Canada. It is also important that CADTH highlight requests requiring a full or significant Indigenous lens. And with an Indigenous Advisory Circle, we could lean upon the subject matter and cultural expertise of the Indigenous Advisory Circle for these matters. It was also important that we require requesters to identify Indigenous partners and how the request would benefit and support Indigenous peoples and Indigenous health and wellness. It is only through the lens of Indigenous people themselves and through how any work could benefit those communities that work should be done. And finally, it is important that there is a templated report language created so that any requesters seeking to intersect their requests with Indigenous knowledges and medicines would know that CADTH does not have the cultural competency to assess this knowledge, and they should seek that expertise within the cultural realm of Indigenous peoples and communities. So how do we move forward? As far as CADTH, we're looking to continue our work with reconciliation and looking to seek out opportunities to engage with Indigenous peoples, communities, organizations, and governments. We also are seeking to explore options for expertise and guidance for both CADTH work with Indigenous peoples as well as other equity-deserving groups. And then finally, we'll continue to review, update, and revise processes to address colonial practices and ensure that CADTH is an effective ally, advocate, and amplifier of Indigenous and other equity-deserving groups' experiences and truths. And now I'll be handing it over to Renata, my colleague, to speak around equity-informed health technology assessment at CADTH.
Thanks so much, Emil, and thanks as well, Avi, for setting the scene. I'm going to now talk a little bit about how we have begun to apply some thinking and methodologies around equity in health technology assessment processes and practices at CADTH. Next slide, please. So if you start by sort of just looking at the definition of HTA, or the current definition, as we know, it's a multidisciplinary process using explicit methods, but also in that definition is this goal of promoting an equitable, efficient, and high quality health system. So while we have equity as a goal of health technology assessment, there has been, however, limited attention to how to implement and think about equity within HTA, although increasingly so from here. There's been a lack of consistently defined and applied methods and measures of health equity impact. Yet the equity implications of doing and applying HTA are inherent, as this is very much a priority setting exercise and resource allocation initiative for healthcare systems. Thinking about equity-informed HTA can begin to facilitate a systemic and comprehensive focus on health equity and ideally enable the delivery of more equitable health outcomes. Next slide. So CADTH has begun to think about, implement, test, and refine some of the tools that exist out there to think about health equity impact within the work that we do across the health technology lifecycle. I'm highlighting three kinds of tools here, but I'm well aware these are based on decades of theoretical and practical research around health equity, and that there are many more tools than this that exist out there. So the UNETA core model is one of them. This is the European Network of Health Technology Assessments core model for HTA, specifically within their ethics analysis domain, pose several equity relevant questions that can be applied specifically to the context of HTA. I'll be talking a little bit about this as we move forward. There are other sort of tools or acronyms such as the Progress Plus framework, and many of you may be familiar with this one. Its use has been wide beyond HTA at this time. And this is a list or set of characteristics that can stratify health opportunities and outcomes or facilitate subgroup analyses across these types of groups. And again, I'll talk a little bit about this in the following slides. And then there have been quite specific HTA-focused equity tools, such as this the Benkalti et al.'s equity checklist for health technology assessment. And we'll also talk about the application of this one as I move on to the next slide, please. So thinking about equity-informed HTA at CADTH, we've really begun to think about equity think throughout the processes and practices of how we are doing health technology assessment, beginning at the stages of topic identification and scoping. So which technologies should be subject to HTA, and how do we frame these? If we embed equity within that thinking, that can set the stage for further thinking about equity throughout the HTA process. We're beginning to also think about equity in our literature searches and information retrieval processes, in our methods to assess health technologies, and in the publishing and tracking of results. At CADTH, this is supported by stakeholder engagement, including patients, clinicians, and other stakeholders to inform this thinking around equity, and by CADTH's commitment to inclusivity, diversity, equity, and accessibility, as we've discussed. Also happy to let you know that some of more in-depth look at this work across CADTH was published in the Canadian Journal of Health Technologies article just yesterday, actually. Next slide, please. I'm going to now sort of, again, overview specifically methodologies to assess health technologies, and this is also further developed within the article I had just referenced. We're beginning to think about a focus on equity in our reviews of qualitative evidence, in our quantitative clinical reviews, and increasingly so in our health economic models. The final point is our reviews of ethical considerations, which, as you can imagine, has many equity impacts, but I'm going to, in the next few slides, speak specifically to some of how we have incorporated equity methods in our ethics reviews. So, next slide, please. All right, so I'm going to speak about our ethics reports for complex pharmaceutical reimbursement reviews. These ethics reports are applied when there are complex pharmaceutical products that come through CADTH. We've applied the Benkalti et al.'s equity checklist for HTA, which I had referenced before, as well as items from the UNETA core model for HTA to look at equity, as well as other ethical principles that arise across 4 domains of interest that are relevant to the context of decision-making in pharmaceutical policy. We look at questions around implications in the target population, or the population which the therapy is aimed to treat, by asking questions such as, are there existing disparities in the incidence, treatment, or outcomes of the condition? We look at equity implications in the evidence used to support or evaluate the therapy under review by asking questions such as, were our clinical trials representative of the target population? Are the thresholds used to define improvements or deteriorations in outcome measures appropriate for all population groups? We also look at equity and ethical issues in the use of the therapy for patients, caregivers, and clinicians, including, are there factors that could prevent a group or person from gaining access to the drug or intervention? We also look more broadly at health system considerations, for example, by asking, how does the distribution and supply of the drug or intervention impact inequities in health outcomes? These analyses are informed by reviews of published literature, as well as engagement with expert clinicians and patient inputs. So next slide, please. I'm going to now take a bit of a deeper dive into 2 of our complex reimbursement review ethics reports and look at some of the equity considerations that did come out in these. So the first one is sulticabtagene autoleucel, or Carvykti, which is a CAR T cell therapy for the treatment of multiple myeloma. By using the framework identified in the previous slide, we were able to draw out equity considerations that informed the ethics report, as well as the recommendations report for this review, including those related to disparities in the incidence, diagnosis, and treatment and outcomes of multiple myeloma, especially as they affect people who are racialized, structurally marginalized, have lower incomes, or face other barriers to healthcare, as well as people residing in rural areas. We also looked at the representativeness of the clinical trial, the pivotal trial supporting this therapy, including limitations in inclusion of racialized populations. We looked at access considerations in the uptake of this therapy, including those related to geographical access, and again, especially as they disproportionately impact racialized, marginalized, lower socioeconomic groups, as well as patients lacking caregiver support who may experience severe disadvantages when it comes to traveling to far distant cancer centers to receive this therapy. We also looked at different cultural meanings around cell and tissue ownership, retention, and disposal, as this is a cell and gene therapy and often requires the sending of cell and tissue materials, often across national borders. There is a need to attend to the needs and values of diverse patients and communities in thinking about cell movement. The second example we have here is for Pluvicto, and I'm not going to try and say the full name of that one at this time. And this is a radiopharmaceutical therapy for metastatic castration-resistant prostate cancer. For this one, our ethics analysis was able to also identify disparities in the incidence, treatment, and outcomes of this form of prostate cancer, especially as they affect racialized, transgender, and gender non-binary people. The need to confirm prostate-specific membrane antigen, or PSMA status, is required for the use of this therapy, which also requires access to PET-CT scans. These are extremely limited in Canada, and the geographic access considerations as well as financial access considerations are significant in thinking about this therapy. As well, patients who do receive Pluvicto will become radioactive for a number of days after receiving this therapy. This causes significant challenges for those who live in crowded or shared living spaces and cannot isolate for the duration of days after which they have received this therapy. So those are a couple of examples, and to show how we've sort of identified sort of equity considerations within our ethics report. So just next slide, please. So as a sort of overall assessment, while we have these tools to identify where equity considerations or consequences may arise, we're beginning to implement methods or approaches for how to describe, analyze, and report on these, although further development is probably needed here. And to support those methods, there's an ongoing need for data or information infrastructures to support these analyses. And this will likely require broadening of the types of evidence used to identify and evaluate health inequities. Next slide. And as we're thinking about the application or thinking about equity in evidence, I think we also need to think about equity of evidence and recognize and consider the inherent inequities in the evidence base and how it is conceptualized, including what counts as legitimate evidence and who produces it, how this evidence is disseminated and who does and does not have access to it, and the challenge of quote unquote mining data from equity deserving groups. And Emil spoke a little bit about Indigenous data sovereignty, the OCAP principles, and there has been a long history of research ethics challenges for equity deserving groups, and we need to think carefully about the inclusion and need for this data. And next and final slide, please. And I think, you know, there's a need to think about also the implications. What does it mean to name equity or inequities within HTA? What are the policy and practice implications of identifying inequity considerations? What are these upstream for health innovators and the ways in which health technologies are designed? And what are these downstream for policymakers, funders, health systems, and clinicians and patients? And with that, I'll hand it back to Suzanne for the Q&A.
Thank you to Renata, Emil, and Avi. You've given us lots to think about. We're going to open up the Q&A session. So just a reminder that you can submit questions through the Q&A tab at the bottom. Renata, a first quick question for you, which is, during your presentation, you referenced an article that was just released yesterday. Can you remind folks which journal that was in, and if you happen to know the title of the article?
So it's actually in CADTH's journal, the Canadian Journal of Health Technology. Is available on the CADTH website. It's in the October edition. The title is Health Equity and Health Technology Assessment at CADTH, or something quite similar to that. Apologies, I don't have it right on hand.
Thanks, Renata. The other question we have, I'm going to read out so everyone has a chance to hear it. And then there's a couple of individual questions as well coming in for others of you. So the first question was, it seems that there's mixed concepts about equity. One that talks about how individuals are treated and whether it's based on their needs and their situation. And the other is on the outcome of treatment. I can imagine that the former one is more in our control within our ethical roles and responsibilities, while the less is less controllable. I thought maybe I'd start with you, Abby, because I suspect this is something you deal with quite frequently in your job.
Thanks, Suzanne. This is a really thoughtful question that has a lot packed into it. So I'll try to do my best to start to unpack some of that. And I guess I could answer in two different ways, sort of more theoretical and more personal. I'll start with theory. So I think what you're getting at here really takes us back to that metaphor that I put up in my slides. When thinking about individuals and their personal circumstances, how they're treated, what their needs are, what some of their situations are, that's really core to thinking about equity, right? We want to make sure that to some degree, to the degree possible, we're able to be thoughtful about those differences and to create interventions, solutions, tools that attend to those differences such that people are treated in equitable ways. In other words, someone who is needing more or needing something specific that the mainstream or that typical approaches might not focus on, that specificity, that uniqueness is attended to. The issue of equal outcomes is not something that's always under our control, and it's something hard to angle towards and achieve. But I'd argue that it's not something we should totally put to the side and say that we're sort of impotent to deal with. This really gets to social justice for me. So, you know, while we won't necessarily achieve equal outcomes for all of the time, we can be really thoughtful about our thinking about structural inequalities, the way our systems are designed, the way our institutions are set up, who's in and who's out of that moral community, who we're focusing on, such that we change the system in order to deal with some of those inequality outcomes. So that's sort of how I think I'd start to help us think about those differences. And, you know, at a very personal level, I feel, Suzanne, I'm challenged to do this all of the time. When I treat kids with cancer and their families, and everyone, well, what I always marvel about cancer in kids is that it doesn't discriminate in the worst way, right? By and large, I see patients and my colleagues see patients from all walks of life, from all ethnic backgrounds, from all socioeconomic backgrounds, from all parts of our country, from all socioeconomic strata, etc. And so many different children can get cancer and have to live with it and through treatment. How they deal with that treatment varies hugely depending on a host of personal circumstances and also systemic ones. And so to the best of our ability, when creating a treatment plan and walking the journey with a family through therapy, we really try to attend to both of those things.
Thank you so much, Abby. A lot of common themes coming through in a few of the questions, and maybe Renata, I'm going to toss this next question to you, which is there's some questions about, you know, the work that we're doing at CADTH in the ethical considerations and equity. How is that actually impacting the recommendations? And I think you'll see there's some questions about, is it impacting our economic model? In the two examples that you gave, did it influence the outcome, and sort of where to next? So I don't know if you'd like to just hum a few bars on sort of, you know, where we are on the journey at this point.
Sure. So there's actually been a increase in volume of our ethics reports, which means we're commenting on ethical issues in more health technologies and pharmaceuticals that come across CADTH, and this is very much in part because a lot of those products are looking a lot more complex, and they're also looking a lot more uncertain, and they're also looking like they have a lot more implications, you know, especially for resourcing, for costing, all of those sorts of things. So how is that influencing, you know, the recommendations that come out of that? Well, as we're seeing this increase, we're seeing our committees, our expert committees grapple more and more so with the ethical considerations, I think, across products, medical devices as well as pharmaceutical products that come across the committee tables, and are thinking about how these factors might influence how we think about clinical trial evidence, for example. So we talked a little bit about representativeness in my examples, but there are implications beyond that in terms of diverse patient needs and whatnot. And also thinking about how some of these ethical implications might interplay with the economic models, and how economic models can begin to think about again, a diversity of patient interests, or a diversity of interests in the modeling itself. So we are seeing this, and I think this is quite recent for CADTH as well, but if this is being outlined in our recommendations reports and being discussed at the committee tables, and is a part of how we are thinking about and recommending around the funding and reimbursement of health technology.
Thanks, Renata. Emil, you're relatively new to the organization, and I always think about the work that you're doing within the organization, both about this conversation and the questions today are a lot focused on the methods and the science, but there's also a piece that's about us as an organization. So I don't know if you'd like to talk a little bit about sort of IDEA generally here at CADTH, and how it affects not just the science pieces, but also us as the organization that executes the work.
Thanks, Suzanne. I think for us at CADTH, but also us as individuals and anyone working in health systems across Canada, I think it's important to recognize that equity is a very big topic, as folks have even mentioned in the Q&A. It can be defined differently, and Avi even brought forward multiple definitions of equity based on the theory that comes behind it. And I think it's also really important to recognize that if you're looking at IDEA, so inclusion, diversity, equity, and accessibility, and the dimensions of differences that might intersect with IDEA, every particular group can have a very different experience of equity or inequity in health systems. And so what I would encourage folks to do is read the In Plain Sight report, as mentioned, when thinking about Indigenous perspectives. But also, there's been some really great work recently done around the social determinants of health in Canada, which follows about 12 different factors, including socioeconomic status, culture, gender, race, to really seek to understand how different groups might experience health inequities in Canada. And then my final thought would be that self-determination is key. Regardless of what systems we can put forward, it is really important that at the end of the day, the decision-making is also put forward or put into the hands of equity-deserving groups themselves.
Thank you very much, Emil. I think, Renata, I'm going to put this question to you, but you might want to hand off to one of your colleagues as well. Is how will CADTH come up with a single definition to define equity? Jurisdictions may have different understandings, and yet hopefully CADTH products can speak to the decision-making process across jurisdictions. So any thinking on the definitional piece of this?
So I'll answer briefly first, but I will hand this over to Emil after that, who is actually doing some of this work on the ground and at CADTH. And I think my opinion would be that it's somewhat difficult to think about a singular sort of definition of equity, given the multiplicity of sort of practice opportunities that it could be applied within CADTH. And I think that's because CADTH has such a sort of wide reach in terms of the activities that we're engaging in. So I think there needs to be a kind of almost series of definitions that are applied to the different kinds of activities, both within CADTH and I sort of put that forward as a broader statement. And I'd also sort of need to think more about well, what would be the purpose of having a singular definition, and how would that improve work? And I think that's something that would need to be thought carefully about as well, versus a sort of, what is the context of the problem we're dealing with here, and what are the equity implications of what we're dealing with here, and sort of then let's think through how we're going to define the problem within that. Thanks. That said, I will hand this over to Emil as well.
Yeah, just being mindful of time. I think it's just important Abby did a great job of really ensuring that we understood the difference between equality and equity. And I think what equity really does is seek to ensure that everyone, regardless of their perspective or where they come from, they're enabled to engage in the ways that make sense to them. And I think when thinking about the work that we do at CADTH, we need to take that lens and look at it through the groups that we're looking to seek to engage with, the methodologies and practices we use, how those methodologies and practices and products are then implemented, and then, yes, what the outcomes are. And so I feel like if we don an equity lens in all of those aspects of our work, then we'll start to uncover the first parts of equity. I think it's going to be a lifelong journey, not only for individuals, but healthcare systems across Canada.
Thanks, Emil. I have to tell you, I wish we had another 10 minutes for Q's and A's because I've got some based on the questions I would love to ask. But recognizing where we are in our time, I'm just going to go around in the same order that individuals spoke and ask for sort of their key takeaway message for you today. If you could just have one message resonate with the audience today, what would it be, Abby?
Thanks, Suzanne. I'll try to be brief. I think maybe I'm going to leverage the last question around definitions of equity and the really nice answers Renata and Emil gave, and harken back to my metaphor, which I hope I don't push too much. I really do like to think about equity as a kaleidoscope, and I think a single definition of or single way of construing or deriving meaning about or measuring equity is going to be insufficient. I think we need to be really thoughtful about invoking different ways of knowing, different perspectives across our broad populace in Canada, and being really thoughtful about angling towards justice and not just narrow conceptions of equity. And I think there's lots of beautiful ways to do that in some of the work Renata showed, and some of the work Emil and CADTH are engaged in more broadly.
Thanks, Abby. Emil.
I'll be quick here. It'll just be to remind everyone that equity itself can sometimes be inequitable based on the dimension of difference you're thinking of. So don't forget to think about multiple dimensions of differences as well as the intersection of those differences.
Thank you. And Renata.
Yeah, I mean, I think, health technology assessment really cannot be agnostic to the problem of health equity. Like, these challenges are embedded within health technologies right from their design through to their implementation. And so we need to make this transparent. We need to name this as part of the commitment to sort of fairness and justice within the practices of HTA.
Thank you all very much. There's many more questions, and for those of you who are participating, we use the questions to think about other things that we'll do in the future. So thank you for posing them. I'd also like to thank each of our speakers for the time that went into preparing for today, and the generosity of your time to speak. I'd like to thank also the audience we have. It's wonderful to see so many people with interest in the topic. A reminder that you will see a short evaluation pop up. Please take the time, if you have it, to be able to give us some guidance about what's important to you for future events. And speaking of future events, just to raise awareness, I just want to let you know that we have several other exciting events coming this fall. There is a national town hall on real world evidence later this week on October 22nd, where CADTH and the Canadian Association for Population Therapeutics, CAPT, are collaborating on a pre-conference workshop to share updates on national and international work. On November 2nd, CADTH will host our fall update, where we'll examine our progress at the halfway point of our strategic plan and what our plans are moving forward. And finally, at the end of November, we'll be having a webinar on CADTH's work on emergency room overcrowding, a topic that many of you may be interested in. Again, thank you for joining us today to mark World Evidence-Based Healthcare Day. Please take the opportunity to engage in other activities related to this important day. Thank you. Merci, miigwech.